Our last speaker is Carol Fowler Durham from UNC Chapel Hill. Dr. Durham seamlessly integrates excellence in teaching with long experience in practice and scholarship to improve ways faculty prepare the future nursing workforce. As a member of Robert Wood Johnson Foundation's Quality and Safety Education for Nurses project, she developed simulation-based educational experiences that reflect cutting-edge pedagogy. Dr. Durham has made significant and sustained contributions in interprofessional education and is a leader in preparing faculty to integrate quality and safety into their curriculum and their teaching. Disseminating her work widely via publications, presentations, and online modules has extended its impact around the world. Dr. Durham is a visionary leader in practice-based education and is a highly sought consultant by simulation and skills laboratory faculty. Dr. Durham exquisitely guides faculty to creatively address the practical challenges of teaching practice. She exudes such confidence and enthusiasm for excellence in teaching, practice, and scholarship that faculty are inspired to continually pursue innovation and creative approaches to improving students' preparation for practice. Dr. Durham's expertise and innovations in quality and safety education have been widely recognized. She is a fellow in the American Academy of Nursing and the National League for Nursing, Academy of Nursing Education. Dr. Durham received the 2010 Academic Achievement Award from Western Carolina University. She received the Alumni of the Year Award from the University of North Carolina and Western Carolina University in 2008. In 2005, she was awarded the Nurse Educator of the Year from the North Carolina Board of Nursing. She is immediate past president of the International Nursing Association for Clinical Simulation and Learning. Please welcome Dr. Durham.
Thank you, Jerry. So, I am excited to be with you at the end of the day, and I appreciate your engagement to stay and to ignore the competing priorities that are pulling you outside that door. We are going to have a fun time for the next 2 hours as you continue to be engaged. I've been impressed with your engagement, and the amount of resources that Gail and Jerry have given us has just been wonderful. And I am taking notes as furiously as you are, hoping to improve my practice, because isn't that what it's all about? Always improving what we're doing. We should never be satisfied with where we are. All right, so our challenge really is coming out of the Committee on Health Professions Education for what used to be called the Institute of Medicine. And this came to us in 2003. I was on the original CUSUM team because it was incubated at the University of North Carolina at Chapel Hill. And in that team, we really looked at this definition to guide where the competencies came from. So it's all health professionals should be educated to deliver patient-centered care as members of an interdisciplinary team, but now we more commonly talk about that as interprofessional, emphasizing evidence-based practice, quality improvement approaches, and informatics. And then safety was added as an extra competency. So our objectives today is really looking at what's the impetus for change, the healthcare areas that we've heard about already, to examine simulation-based learning as a way to enhance that focus with quality and safety, and also to apply the technique of debriefing as a way to create reflective learners. So, you have a piece of gum. I would like for you to take that piece of gum and break it into 3 equal pieces. Those 3 equal pieces should be judged by someone who's sitting next to you. Are they equal or not? Somebody said kind of, sort of, maybe. Okay. And people are creative in the way that they're doing it. Some people have done it horizontally. Others have done it, vertically. So, or half and half. So, okay. So keep that in mind. So, generally, would you say, is it good enough? Good enough for dividing a piece of gum between 3 people? I would say yes. So if we had good enough and we said, well, it's 99%, 9% equal, we consider that outstanding, particularly if we made an investment and we got that kind of return, we would be dancing in the streets. If you're a researcher, if you got that return on your survey, you would be so ecstatic. So 99.9% indeed is great, and we would even call it excellent at some point. But I'm asking you, where does healthcare fall in that 99.9% as a standard of excellence? Think about the GOM. If it was important that we got that exactly into 3 different pieces, we would have to take a ruler and X-Acto knife, correct? And sometimes in healthcare, it is that important. If you're given a dose of a medication that is going to be therapeutic, it has to be exact. Or if you give it incorrectly and it's deadly, then it has to be exact. So let's look at, this video was about 2 different perspectives. So when you think about it, what were they? Well, they really were about the 99.9% perspective and the 0.1% perspective. In actuality, I'd like for us to consider that it was about those percentages, but not really. It's really about 2 different groups of people. Those who are in the 99.9% group and those who are in the 0.1% group. So good enough, is it really? The concept of good enough is at the heart of mediocrity. And you might remember Gail saying early on, she says to her students, who in here would like to be mediocre? And no one raises their hands. And none of us want to be mediocre, nor do we want our learners to be, our providers. But software companies are released with known defects. Toys are manufactured with an eye on profit instead of safety. Food products are shipped with acceptable amounts of foreign matter, which we don't want to know what it is. So are we settling for good enough in healthcare? Sometimes I'm concerned when we say, well, we're just human and errors happen. Are we settling for less than and for good enough? I think if we take that stand, then we will always have that mantra, and harm will always occur. We have to strive for excellence when good is not good enough. So 0.1% is insignificant only when it is not you or somebody that you don't care about. So if you go back to the gum, you can now chew your gum, you can just throw it away, whatever you want to do. But the idea is it helps us to reflect on something that is non-sequential, like a piece of gum, or healthcare, which is sequential. So we've talked about medical errors, and I'd like to change that to be healthcare errors. Because in actuality, when the public hears medical errors, they think it's our colleagues in medicine. But in fact, it is all of us that contribute to that error. So one of my missions is to change that word to be healthcare errors. But we think about how dangerous is healthcare. You can see here, this comes from Lucian Leap's work. And in actuality, healthcare is as dangerous as it is to do bungee jumping and mountain climbing. We are much safer being on a railroad, being in a nuclear power plant, or living near one, or even flying, even a charter flight. So healthcare is really dangerous. So you go back to how often people would be coming out of the air if healthcare was like aviation. How many people would book a flight? If you know that every 3 days, 174 flights would crash, you would not be booking a flight. Healthcare, the thing that was sentinel, and I think that this is one of the things that Gail talked about, why is quality and safety becoming more and more important? For all the reasons that she and Jerry have talked about, but I'm going to talk about one other, and that is the patient. As people wrap their heads around that it is unsafe to go to the hospital, that they are so much better off not being there, then they are going to begin the call that says, you have to do something different, because I'm not going to come to your hospital until you show me the evidence of what you're doing that is better than the hospital down the road. And then it will be a whole different place and game. I have a hard time with numbers, and so I'm a visual learner. It is so much easier for me to wrap my head around a picture. So we talked about 44,000, 98,000 people dying, and that comes from the IOM report from 1999. John James is a colleague that we know, re-examined those numbers, and he believes that because times have changed and the more studies have been done and the reporting is different, there's up to 400,000 people who are dying. He even thinks that that is even underestimated. 400,000 people. How many people would go anywhere where they knew there was a chance of 400,000 people dying in a year? This is the picture of our national cemetery. The National Cemetery holds 400,000 graves. So when you think about looking out across that cemetery, we in healthcare are filling that cemetery every year with preventable healthcare deaths. That is not acceptable. That's why we have to change. So you think, okay, healthcare needs to change, right? But as educators, we are contributing to that. I've been teaching for 30-some years, and so I am part of that era, as are you. And until we teach differently, we cannot expect to have an outcome that is different than this. So we have to do something different than what we have done in the past. So we're going to use story as a way to develop the cues and competencies. Story really does put healthcare era into a perspective of having a face. It's so much easier to dismiss numbers than it is to dismiss people. And so it also applies the knowledge and experience to a real-life situation and gives us situated cognition where we can understand it. And then it ties action to outcomes, and it's memorable. Because if I just gave you the numbers, it would be hard to remember. But if I tell you a story, you will always remember. So I'd like to tell you Sue Sheridan's story. We've talked about team steps, and when you look at that free literature online, in your packet you have a list of about 8 pages of resources from me. And in there are a lot of the things that we've already talked about, but Team Steps is located there, and this is a video where she tells this story. So Sue Sheridan said that she was a new mom. Her first baby, Cal, was born, and Cal looked a little yellow. And she thought, he's jaundiced, and I know that that's not good, so she called back to the healthcare and said, the baby's jaundiced, and they said, are you a new mom? And she said, yeah, and she said, oh, honey, they get a little yellow, but it's going to pass. And so she kept on talking about it, and she called back, and before they saw him, he had such a high bilirubin that he had cerebral palsy for the rest of his life because of that era of dismissing her and not listening to her. And so it could have easily been prevented, but they did not. They just assumed, oh, she's an overreactive mom. That is not patient-centered care. Her husband, a few years later, began to have some headaches. And he went to the doctor, and sure enough, they found a brain tumor. They did surgery, they removed the tumor, and they sent it to the lab, and the lab report came back, and they said, we'll let you know if there's any problem. The lab report came back, and it got laid on the desk, and it got filed before anybody saw it. And so in a few months, he began to have headaches again. And they went in and found that the report had been a malignant tumor, and that now it was inoperable, and there was nothing they could do, so he died. So you look at this woman who's had 2 major healthcare errors occur in her family, and she has a mission now for trying to make that different. So, but you look at this idea of patient-centered care, and when we say to people, if we don't hear from us within a week, call us back to see what the report was. Then we incorporate them fully into their care. Or if you listen to a mom, and this is the cues and competency that we already talked about, using the data to actually listen to the patient. And then the quality improvement, what if that office practice was nothing gets filed until there's a signature from the provider that they have seen it and the date that they called the patient to report it, and then it gets filed. So there could be a quality improvement process that occurs. So with that story, you can highlight a lot of the cues and competencies. So I'm going to quickly go through several examples of ways to help you take these stories and integrate them into your teaching and or orientation programs that you can use. So the next story I'd like to talk about is Josie King. Josie King was 18 months. Several of you are nodding your head. You've heard of her story. We actually have our fundamental students read this as a book club, and then we get ready with some discussion questions, and we Skype in Sorrel. And they're able to talk to her about that story. And she's very willing to come in and talk to our students in that mechanism. But Josie was in the hospital. She had gotten crawled into a tub that she ran herself, a hot tub of water, and got burned. And so there was a lot of chaos at the house because they were moving, remodeling, and it was the holidays. So when they missed her, they were like, "Where's Josie?" And then all of a sudden they heard the scream, but she had gone upstairs to run the bathtub to play with the boats in the water. And she had only cut on the hot water. And in cutting on the hot water, in the examination of what happened, the hot water was set at 140 degrees. So it was too high for safety anyway. So she was burned and she was rushed to the hospital, and they were so excited because they were just moved to this area, and this was the most amazing hospital, and they were so fortunate to be here. They walked around in the hallways, and everywhere they went it said, "We're the best hospital in the nation, we're #1, we have excellent ratings," and they talked about that all the time in all the media that was around. They were so relieved. So Josie's getting ready to go home in about 2 days. And so the kids who are on the rungs of that ladder with her are preparing a coming home party. They're making posters, they're fixing cars, they're getting balloons all over the house, and they're getting ready for their baby sister to come home. So Josie is a little lethargic, and her mom says to the doctor, "I'm worried about giving her any more medication, so let's just not." He said, "I agree, we won't, and let's just hold that." In about an hour or two, the nurse comes in just before lunch, trying to finish out giving her medications at 1 o'clock, and she has methadone in her hand. And Sorrel says, "We decided she doesn't need any more medication, so I don't want you to give it." And she said, "Well, they must have changed their mind because I've got it as an order and I need to give it." Stop when a patient says that, right? Tell our students, stop when a patient says that, and go check it out. She said that Josie had not ever cried for the whole time that she was in the hospital, but as that nurse pushed that methadone into her vein, a big crocodile tear came out of her eye, and she arrested. She says that she was conflicted at the moment that the nurse said no, that she should either jump up and knock it out of her hand and run into the hall and scream for help. But then in the back of her mind, she said, "This is the best hospital in the whole nation. It is an excellent place. I'm safe. This nurse is smarter than me. I should let her do what she needs to do." So she was brain dead, and in examination, they found out that she was actually dehydrated, had sepsis, and also had, too much medication on board. So, but instead of stopping, and if you go back to what Gail had said, there was a list of things that could have prevented any of these deaths if we had just intervened at the right point. So the litigation that followed, she was able to take that money and develop the Josie King Foundation. And that's a website that will give you lots of different types of resources as well. And it's on this slide so that you can see that. So you think about safety, minimizing the risks of harm to a patient in providing through both systems and effectiveness and individual preference. So safety was ignored as a cues and competency in the care of this patient. And also informatics, if we had gone back and looked at the data about her temperatures and her vital signs and all the things that were happening in addition to the physical exam, might have recognized that she was dehydrated. They talked about her sucking on a washcloth when they bathed her. They talked about her being so thirsty once she got a hold of anything to drink, she slurped it down. If anybody was noticing and putting all those pieces together, then Josie would not have died, and she could have gone home to that party. But instead of going home to the party, Sorrel had to go home to a house with kids. Her husband was in the air, flying to a conference that they both decided was okay for him to now go to. And she had to wait till he landed to tell him that his daughter was dead and that he needed to come home. Those are not the conversations that we want to have. And then the last one is one that we've talked about several times. And I just want to go a little bit more in depth, and I appreciate Jerry and Gail kind of setting this up. Lewis Blackman was probably the first face to medical errors that I saw. And on the handout in your thing, you have actually the link to that streaming video. We use this in our interprofessional course, and we watch this together and do a reflective paper on it. But the point to recognize is that Lewis was healthy. He was 15 years old. He goes in for elective surgery for pectus excavatum, and he goes in on Thursday, and all things are looking good, and Helen and her husband and family are beside him. So on day one, he has the surgery. They know it's going to be an arduous recovery, but it's low risk, and so he gets the epidural ketorolac as a pain management, and so he gets that when they get ready to discharge him from the OR, the recovery room cannot find a bed, so they put him on oncology instead of surgical post-op, because that's where the bed was. And so he has low urinary output in the recovery room, and that's not really highlighted, nor is it told to the family that we need to watch his urinary output. So days progress on, and he begins to have signs and symptoms of this kind of huge abdominal pain. It's like a 5 out of 5. It's a sudden onset. It's incredibly painful. And then he's not able to walk without tremendous support. He's getting diaphoretic. He's getting pale. And a nurse goes in and recognizes that there's something odd happening here. And so she goes out into the hallway, and everybody has decided that this is gas and constipation. He had chest surgery. He did not have abdominal surgery. Now, he is taking narcotics, but he is not, why would we jump to gas and constipation? So that's called confirmation bias or premature closure. And when we do this in our simulations, we have found that students will sometimes say, like, for example, the case might be really about serotonin syndrome, and they might think it's sepsis. And so one of my physician colleagues said, when they decided it's sepsis, no matter what happens, if an elephant were to walk in the room, they would look up and say, look, it is an elephant, it must be sepsis, because it will make everything fit into the diagnosis that they have already anchored upon. And we anchor upon it, and it's like moving the Titanic. You can't move the thinking of someone. So now we teach all of our students, even nursing, to have 3 possible diagnoses, not to only have one, and only rule them out when you're able to rule them out. Don't just dismiss them. So in that process, what do you imagine that nurse was thinking? When you see these symptoms with Lewis, what might she have been thinking? Somebody? He's pale, he's diaphoretic, his abdomen is hurting him. When she laid her hands on it, it was tight. Abdominal bleed, right? Something's happening there. She goes out, she expresses her concern, and then she comes back and she tells Helen, oh, it's just constipation and gas. What happened out there? Somebody, I don't know where she was in her training or was she a new nurse, but somebody dismissed her and didn't say, well, let's get a flat plate of the abdomen and just see what's going on. They just said, no, honey, she's an overreactive mom, or whatever they might have said, and just say it's just gas and constipation. So she comes back in with the party line, and she stays with it. So who are in the power gradients that we have? Oftentimes, we always talk about physicians and nurses. There are many power gradients in the hospital. There are clinical instructor to students. There are nurses on the floor to students. There are nurses to nursing assistants. There are the whole healthcare system to patients. So all of those power gradients exist. We have to include the patient and their families into these teams. So on day 5, his pain suddenly went away. And so the physician who he told that to said, oh, good. You know, sudden pain that goes away is bad, right? So a few hours later, they're talking to the surgeon who is now in surgery again, who had gotten a report that Lewis was okay, and they're saying something's bad wrong with him, and he's like, I got a report he was good. I'm in the middle of this surgery. I can't go now. So 100 hours later, from the time that he had the surgery, they're now getting ready to do blood pressures, and they can't find it. So they go and search for 2 hours, find 7 different cuffs, take his blood pressure with 12 different devices, because his pressure is in the 70s. Instead of someone saying, could it be the patient and not the equipment? And what if it is, oh my God? So the only thing I can figure out is that they didn't want to believe that this could be true, and it had to be the equipment. So we have to teach our learners to stop and think. If the symptoms are telling us one thing, no matter what everybody else is saying, you need to go with what you're seeing and what you're feeling intuitively. So why go to equipment failure? So at 9 a.m., the surgeon just dismissed the report, and so what we have now done is line up the Swiss cheese, and this story is so familiar to me, I can tell you all the pieces of cheese. The first one was low urinary output. The second was he was admitted to an oncology floor. Can you imagine an oncology nurse seeing someone who has pain, nausea, fatigue? Is that normal? All the patients on the floor have that. That is not really odd to us. So the whole idea is that they should have been empowered to call a surgery post-op nurse and say, can you come down and look at this kid with me? This looks weird. I don't know. He looks like our normal patients, when in fact, he's your surgery post-op patient. So then he's on Ketorolac. Ketorolac is a black box warning for GI bleed. So all those things lined up, and in the autopsy, they were able to find out that his, well, I'll tell you, the night nurse concerned, she was dismissed, and the team had prematurely closed on the being gas, and no one had been used to the cuss words that we've talked about before, or the 2-challenge rule, and so impending shock is occurring. So the autopsy revealed 2,000 cc's of blood in his abdomen, 800 cc clot, and he had a duodenum ulceration that perforated the posterior wall. So he bled out into his abdomen. And so notably, 4 years before this, Ketorolac had been a black box warning. So if you had called the pharmacy and say, we're having this kid that's having a hard time with pain management, would you come look at him? The pharmacist would have known immediately that Ketorolac was a black box warning. So who is around the table or the bed that we haven't asked to be there? So the idea is we need to include the right people on the team. Helen said this statement, and this is the most heart-wrenching of all the statements: if Lewis had been anywhere but in the hospital, we could have gotten him the help that he needed. Again, if that's how people felt about the hospital, would they be coming? I would not. I would not take my family member there. So interviews with Helen Haskell are on the CUSUM website, free for you to use in class, about the story. So evidence-based practice, knowing about Ketorolac, applying Ketorolac, knowing about health assessment, applying your health assessment skills, knowing about all those things would be the evidence that we would have needed to save Lewis. And then teamwork and collaboration, having a huddle, saying what I'm concerned about, talking to the pharmacist. Those are the CUSUM competencies that this case would have addressed for us. So one of the things I wanted to talk about is simulation. Simulation, GABA, and this is a picture of him, and it's a little bit hard to read, but it's a technique, not a technology, and I think that's the thing that we have to remember. It is just a teaching modality, just like anything else that you might use. And so to replace or amplify real experiences with guided experiences that evoke or replicate substantial aspects of the real world in fully interactive manner. And so we can't do simulation when it is just watch this, but rather you have to be in it and try it out and do it, because it's important that you are interactive in it. So we talked earlier, Gail talked about Benner's quote, what's essential for healthcare is actually creating connections for acquiring and using knowledge, and we call that teaching for a sense of salience. Simulation really does allow us to do that. There are ideas that you could do for deliberate practice. You can have students learn on a task trainer, then you can actually have them apply it in a simulated lab. Then you could have them work within a team, and then you can have them doing it in a clinical setting. So all those pieces fit together. They're not in isolation, nor is our class lab and simulation labs in isolation. We should make them all dovetail together so that they fit together to create a meaningful learning experience that makes sense to the learners. So simulation is a story in action. So you create space to consider what is and what should be, and what do I need to make that happen. So it allows us to refine our technical skill, and someone talked about that earlier, technical skill development, and it also allows us to develop non-technical skills like communication, collaboration, and teamwork. It's an important tool to develop the more challenging skills of those more complex skills, and that takes a different kind of scenario. When we do this with our interprofessional students, we don't grade them on the clinical technical skills, but we grade them on the communication, collaboration, and the non-technical skills. It provides an experience that we can actually apply the knowledge, skills, and attitudes outlined in the QSIN based upon a clinical scenario. So whenever you get ready to write a scenario, look at those QSIN competencies. They are written in objective form. Some of them are almost pick them up and use them right into your simulation about what you want to happen there. So if you think about using story to create reflection about competencies, I'd like for us to try to do that now. So there's another product out there called Story Care, and the list of it is on your reference. But in your packet, you have a piece of paper that has the Story Care story on it. So I'm gonna, first of all, we're gonna listen to the story. So this story is one of like almost 215. It looks like this in your packet, and it's called The Courage to Make the Call. And what we're gonna actually do, and we can do this easily in a class of 10 or like a clinical conference, or you can do this in a class of 250 because it's very easy to do. So let me walk you through the exercise of what we're gonna do, and then we're gonna actually do it. You're gonna listen to the story, you're gonna take your pen, and you're gonna actually underline the things that you think the team did well in the story as you listen to it. And then you're gonna circle the things where they could do something better, that could lead, something that has happened that could lead to an error. So again, to repeat that, you wanna circle on here what they could have, what could lead to an error of something that they did, and underline the things that they did well. The story is front and back of this piece of paper, and it goes for about 4 minutes, and then we're gonna debrief it when we get back to this, okay? As our technical group continues to work. So would you play the story? Can we hear the story? And this one's entitled The Courage to Make the Call.
Chad Carlson was riding his bicycle one morning in the dark when a car plowed into him at 30 miles an hour, tossing him into the air, after which he hit the windshield. When the medics arrived, he was alive, but nearly every bone in his body was broken. Fortunately, he was wearing a helmet and was still conscious. While he was having difficulty breathing, unbeknownst to him or the medics, his left lung had been punctured. Even the doctors didn't realize how bruised and damaged his lungs were from the impact. During surgery, he went into respiratory distress and stopped breathing. His lung had collapsed. They were able to revive him and finish up placing a foot-long screw in his femur, but postponed the remainder of the repairs. His lungs were in such dire shape that they moved him to the ICU and placed him on a ventilator at 100% and heavily sedated him to induce a coma until he could breathe on his own. During the next 2 weeks, they gradually reduced his ventilator until it reached 30%. At 7 p.m., Carol Moore, who was filling in that evening, came by the nurse's station to go over her patients with Diane Sanders, the day nurse. Chad Carlson was the last patient in their rounds. His wife, Robin, had been at the hospital 24/7 since the accident, but this night she decided it was safe enough to get some rest in her own bed. She had Diane promise they'd call her at any hour if there was a problem or change in his status. Diane impulsively knocked on the door as the two of them came in. The first thing she did was check all the equipment to be certain everything was functioning properly. This is our miracle patient. By all accounts, he shouldn't have made it, but Dr. Jackson thinks we should have him off the ventilator by Friday. Carol was looking over the chart. I see here that the doctor wants to reduce his ventilator setting to 20% this evening, but...
Code blue, room 413. Code blue, room 413.
Over the intercom came the announcement. It was one of their patients on the floor. Carol and Diane turned and ran to assist. It was nearly 8:30 p.m. before things settled back down and the patient who coded was stabilized. Diane slipped out as soon as it was deemed safe, leaving Carol to pick up where they left off. She picked Chad's chart back up and reread the notes. While the doctor had ordered a reduction in the ventilator, he simultaneously ordered an increase in a key medication from 15 milligrams to 20 milligrams. In her mind, something didn't add up. She called Diane on her cell. Sorry to bother you, but I was looking over Mr. Carlson's chart. Did you know that Dr. Jackson's increasing his meds from 15 to 20 milligrams? Diane paused, trying to picture the chart in her mind. Well, that's not right. Are you sure? Carol was emphatic. It's in black and white. What's odd is that he had reduced the med down to 15 milligrams yesterday from 20 when they reduced the ventilator from 40 to 30%. Why would he be increasing it when we're going down further? What do you think we ought to do? Diane didn't hesitate. I think we need to call Dr. Jackson. Carol took a deep breath. You know how he hates being interrupted at night, especially for minor things. He can be a real bear. Diane responded, let him growl. I've got three-way conferencing on this phone. What's his number? Let's get him on the line. A minute later, they had tracked him down. Diane took the lead. Dr. Jackson, sorry to bother you, but we have a question about your orders for Chad Carlson. He was irritated. This better be good. I was just getting ready to read my kid a bedtime story. Well, your orders indicate a reduction in ventilator settings to 20%, while at the same time increasing his meds from 15 milligrams to 20 milligrams. That didn't seem to make sense to us. There was a long pause on the other end of the line. He said, you sure that's what I wrote? She replied, afraid so, Dr. Jackson. There was another long pause as he attempted to retrace in his mind the afternoon and see if he could think of what had distracted him to make such a significant error. He couldn't think of a thing. Taking a deep breath, he said, you're right. That's not correct. Something must have distracted me. Great catch. It should be 10 milligrams. Thanks. You did the right thing by calling. Carol, the night nurse, was gracious. I thought that's what happened, but figured I should just check with you to be doubly sure.